Hello, how you guys doing? Welcome to another edition of I Am Abel Foundation's Medicine Makers, where if your destination is a career in medicine, we're going to help you get there. I'm your host, Cornelius Conway, and we're joined here with a special guest, someone very acquainted with the foundation, a big supporter, does a lot for us, a mentor, Dr. Toyin. How you doing?
Good. How are you?
I'm doing well. I'm gonna let her introduce herself, but she works at Rush University. She's infectious diseases and has a lot of experience in HIV research. So,
All right. So my name is Toyin. I'm an infectious disease physician. I work at Cook County Health, and also I'm associate professor of medicine at Rush Medical College. I've been at both institutions now since 1999, so 20 years, doing HIV work. My clinic is at the Core Center, which is part of Cook County Health, and I take care of adults living with HIV, and also do a lot of sexual health counseling, other infectious diseases, both in the inpatient and outpatient. And like you said, been a big supporter and advocate of I Am Abel Foundation, and very happy to be here
for
tonight.
sure, and we're happy to have you. So today, before we even start the conversation, I'm going to get into some of the things we have going on. We have a huge basketball camp going on at Loyola University Stritch, 303 basketball. We basically have a lot of kids mixed up with physicians, mixed up with medical students. It's August 4th, this upcoming Sunday. Please register. If you don't have any kids yourself or know any kids, tell someone that has kids, ages 5th grade to 8th grade. So tell the boys to come out, play with some of the medical students, play with some of the physicians. We're also going to have CPR, Stop the Bleed, going on, some stitching, anatomy lab. A lot of good things going on, so they should come out, get involved. If they haven't thought about career in medicine, they can come out and see what it's all about. We have that coming up, and we have some more events coming up real soon. We had a CPR event over at Rush University, one of our first Spanish CPR events at Rush. It was sold out. It was free, obviously, but it was huge. Yeah, hundreds of people applying. So please pay attention. Go on iamable.org, iamabel.org, and check out when the next class is in your area. We're all over the city. But today, we're going to be talking about HIV. And specifically, we're going to hit on HIV in its totality, but also specific to Chicago. What's going on in Chicago specifically? So, like I said before, Dr. Toyin has a bunch of research and experience, over 20 years of research and experience in HIV, infectious diseases. And we know that HIV is a prevalent issue, not only in Chicago, but in the African diaspora as well. So before we even get into that, what made you want to get into infectious diseases?
Oh, wow. So what made me get into infectious disease? Obviously interest in the subject matter, but also more importantly, mentors. I during my intern year, so I got done with medical school, and I knew I was interested in internal medicine, and so I was in an internal medicine residency, and I thought I was interested in cardiology because I thought I wanted to be a cardiologist. And very early in my intern year, I got to work with 2 infectious disease physicians at UIC, and just seeing how they cared for their patients, how smart they were, I thought, in terms of coming up with differentials and then following through, implementing it, and seeing how they took care of patients both in the inpatient and outpatient setting. I thought, wow, I want to do more. I want to look into this. And I happened to be on a rotation where we had a lot of people living with HIV. This was back in '95. And just seeing how all the opportunities for caring for patients, for research, and all the work that needed to be done, it was really an easy choice. So by the time I started my second year of residency, I knew I was going to be applying for an infectious disease fellowship. So it really, speaking of which, this is an organization that does mentorship and pairing and stuff. The importance of seeing someone do something and seeing how they do it, and that was really my interest. Before I started internship, I was an internal medicine resident, and I liked a lot of specialties, but it wasn't until I really worked with 2 people in ID very early in my intern year, and I said, this is what I want to do, and haven't felt otherwise since then. Yes. So it really was, and just the opportunities with infectious diseases. And sometimes people think of infectious disease and think about outbreaks only, or what they see on TV, or different things in the hospital. But the beauty of infectious diseases is it allows you to You can practice completely if you want in the inpatient setting. If you want to be somebody seeing patients who are acutely ill in the hospital, in the ICU, you can work completely in the clinics. You can do teaching. You can be just a teaching faculty for infectious disease. You can work for pharmaceutical companies because they do need the physicians to help with drug development and kind of look at where the needs are. You can work for the CDC and do outbreaks. And when there's Ebola somewhere, they send you out there. You can work for public health, right? So the head of the public health, Illinois Department of Public Health, is actually one of our physicians who used to be at Cook County Health, who is a physician, but looking at, so in infectious diseases, you can work in a whole variety of settings, and sometimes you get to work in all of those varieties at different times, and sometimes at different points of your career. So for me, it's been really exciting because I get to do in my current work, I get to have clinics. And so I do outpatient work. I get to round in the hospital. I'm actually on rounds this week and next week. I get to teach residents and medical students and fellows, and then I get to do research, which I think is really, really important. So the other thing I didn't talk about, you could be a complete researcher who does, you're in the lab or you're doing clinical trials across the country and things like that across the world. But, I feel very fortunate to be able to do a lot of those things, which kind of keeps me not bored, but it allows you to kind of grow in different areas. And it's really important, we talk about research in the community, to be able to make sure that new strategies, new medications, new treatments that are available, that our communities have access to those, that our communities are well represented in those trials, so we know that those medications work, that there are protections in place to make sure that people are comfortable with research. And that's one of the things that I really enjoy about being in the county health system, is that making sure that our patients have access to the same kind of medications, but also part of those research studies very early.
Definitely.
But also understanding all the issues around research in the past and in the legacy of Tuskegee and some of those other things, so that we can actually counsel patients appropriately, respect their autonomy, talk to them about risks and benefits at every time, make sure there is no coercion, but making sure that they understand the importance of being part of this trial so that we actually have therapies that work and do well. So infectious diseases, again, that's myself. For anybody who's thinking about ID, it's a lot to do. You don't have to stay in one little box. You get to explore.
And what I think is real cool too is the stigma around infectious disease, specifically with sexually transmitted diseases. And it's great to see a Black physician, some of the diaspora that's really, in that field, and they represent that field. And talk about it.
And a lot of people have, we're having a conversation before we walked in around PrEP a little bit about how even people who are clinicians and physicians and primary care health providers sometimes still have an issue talking about sexual health. And what we're trying to promote as we're looking at getting to zero HIV infections in the state of Illinois, we have a plan that's released, and to get to functional zero by 2030, which is just 10 years from now, is that the infectious disease community needs to continue to do what it needs to do, but we have to expand the workforce. We have to get more people interested in HIV, both prevention and treatment and testing, but we also have to work around the stigma, both for the community, the general community, and for people in healthcare already, so that people are more comfortable around talking about sexual health and HIV testing and STI testing and screening. And we know that unless we change what we do currently and make it not just an infectious disease issue, but a sexual health, So when we think about things, we talked about anytime we kind of put things into silos, people kind of then say, okay, well, that's only these people take care of that. Same issue we have with mental health, and why aren't people accessing mental health is the stigma around it. So if we kind of make it that health is not just the absence of disease, It's a state of physical, mental, social, emotional well-being, and that sexual health is a part of your life. We are wired to be sexual beings, and so when we talk about sexual health as just part of your physical health, then it becomes less of an issue about how do I ask, how do I stuff. And with HIV testing, the recommendations are that anybody over the age of 13 should get an HIV test. That's the CDC guidelines, HIV test. So if you don't feel comfortable as a provider asking about sexual activity, just order the test, blood test. Make it simple. So we're trying to routinize a lot of things so that providers, but also working so that people can actually ask. As you're asking about physical health and mental health, sexual health is part of a complete history.
Making it more normal.
Exactly.
more normal.
Normalizing it. So it's not
Yeah.
an ID thing. It's
For
not
sure.
a prevention thing. It's if you're seeing somebody in a healthcare setting, it is part of their life. And people get very, they're like, oh my God, that's a teenager. And I have a teenager, so I don't want to ask.
Right.
Or like, oh my God, that's like my mom's age. I don't want to talk about it. So we're missing extremes of age because people have their own biases about talking
Stigmatizing
about
it,
it. And,
yeah.
and so we have to normalize all these things.
sure.
And be comfortable talking about it.
Right. And
I'm very comfortable talking
yeah,
about it.
yeah, me too. I think I am as well. You know what? But when we talk about HIV,
Yes.
a lot of times we try to geographically locate it, put it in Africa, like, oh, it's an African issue. But it's huge in the United States. There's a lot of
United States. Yes.
well, in your opinion, we know that, or at least what I've heard was that the first patient zero in North America was a French Canadian. So it's not just a black issue or
No,
African
it's
issue.
not.
It's over here in North America. It's
It
in
is.
South America. It's all over the world. But how prevalent is it in the
the
U.S.
US.
and who does it affect the most?
Correct. So you bring up a great point. So we have HIV worldwide. The vast majority of cases or people living with HIV still live in sub-Saharan Africa.
Right.
Millions and millions of people. But you asked specifically about the United States. So we have about 1.1 to 1.2 million people.
Okay.
In the United States living with HIV, and of those are estimated, it's thought to be about 14%, or 1 out of 7 don't even know that they're HIV infected yet, right? So we've made some progress with testing, right? So in our setting, at the Cook County Health, we do routine setting in any healthcare setting. If you're coming for anything, blood work, the HIV is in your consent to care. Like, we get that done. So just to normalize it, right?
Right.
But there's still, we feel like in the US, the CDC says about 1 in 7 don't even know they have HIV, right? That are living with HIV. But that number is better than what it was. A couple of years ago, 5 years ago, it was 1 in 5. Before then, it was 1 in 4. So we're doing a lot more testing. So 1 in 7. But that's not for everyone. That's for the whole population. When you look at the 13 to 24-year-olds, which have the highest, they have a large rise in cases.
For sure.
It's almost 50% of them don't know that are living with HIV because they haven't been tested yet.
sure.
So what that tells us is that people are sexually active, and two, they're not routinely tested. And if you think about it, especially the groups that are hardest hit, African Americans, Hispanics, and men who have sex with men have the highest rates. And a lot of young people, because if they don't have any medical problems, are not going in to see the doctor.
Right.
So if we talk about testing in the doctor's office, if they're healthy, they've passed the pediatric vaccination stuff, right? But they're not old yet to have all these other things that come with aging, high blood, things that get you into. So we're missing a whole group of people who are healthy and feel fine. And a lot of people with HIV have no symptoms until it's really, really advanced. So we have to think about testing in sites where people go to where people are. And that's a lot of the things that are happening about testing, rapid testing, finger stick testing. There's a 1-minute test you can do. There are things you have to think about, not waiting until people are ill in the healthcare setting, and when they, when they're still under like routine vaccination status. So from 13 to 24, it's thought to be about maybe 40 to 50% of people in that age group who have HIV don't even know yet, and a lot of them are getting new infections. So about 1.1 million in the U.S., and definitely a disproportionate, highest, more than 60% among men who have sex with men. And then in the younger age group and in the older age group, we're seeing increase in cases. And there's still about somewhere between 35 to 38,000 new HIV diagnoses every year in the U.S.
That's a lot.
Still a lot, right? So we've made a lot of advances in life expectancy, lots of advances in new diagnosis. We've made a lot of advances in transmission mother to child, all of that good stuff. But we still have, about 35 to 38,000 new diagnoses every year. So clearly there's still a lot of work that needs to be done.
Right. And we talk about testing. We talk about some of the different types of, ELISA, Western blot testing. A lot of people are skeptical about their tests. How accurate are those tests?
They're great. Those tests are more than 99% accurate, right? And so it used to be, before, a long time ago, where people would have to get an HIV test, and then would have to do a confirmatory test that took about 2 or 3 days. So people would get a test done, in the field, even in healthcare setting, and then they would have to wait the 48 hours to get a call. And a lot of people, between the time they got the test and asked to come back for the results, never did. They got scared, they took off, or the phones changed, you couldn't find them, they were done. So it led to the innovation that we have to have more rapid tests. And those rapid tests need to be user-friendly, they need to be quick, but they also need to be able to check for somebody with acute infection. So there are people who have acute HIV. They haven't formed the antibody completely yet, but the test is reactive. So a lot of testing technology now is what we call the fourth generation
Right,
test.
2 week one.
Correct.
Yeah.
So the fourth generation picks up as early as 2 weeks, and it will look for antigen and antibody, so you
Right.
can pick up. Now, if somebody has a negative fourth generation test and they think they have a recent exposure, we would tell them to get tested again in a
Right.
couple of weeks. But the tests are really good, and a lot of times in most health settings is that if you have that test, it's positive.
Right.
We can do a confirmatory in a clinical setting before you start treatment, but they're really, really, more than 99%
Sure.
sensitive and specific. So sometimes when people get a rapid test and it's positive and they're like, yeah, but there's a 2% chance, there's a 1
Right.
point. It's possible that
Right.
it could be a false positive, but that is so rare
For
that
sure.
the counseling that comes with that is we need to link you to healthcare, and you'll get another confirmatory test, but probably then also get access to treatment.
Right.
Yes.
We talk about
The
positive.
home kits, there's so many
Yeah,
ways to do
there's
it.
a lot
The
of home
home
kits.
test that you can do in
Slight
30
bonus.
minutes, with the swab, and
Right.
it's very user-friendly. Those are a little more expensive.
Right.
But for some people, they don't want to go into a healthcare setting until they've done one at home.
Right.
But it's also, we talk about people, when people are new sexual partners, there are a lot of places in Chicago people can get free confidential testing. Just, gettested.com. You can put in your zip code, City of Chicago, free HIV test. There's so many places in the city, including our health system, but all other places where you can get free STI, confidential HIV testing. Some people are a little still anxious about that. You can buy a home kit at Walgreens, sit in the home. Partners can do it together, and then some people do that, and if it's negative, then they go in, but so there's so many ways. There's a 10-minute test, there's a 1-minute Insti test, there's a swab, and then with regular blood draw, for regular routine blood draw, you can get the results back, right away.
Right. And the thing is, what a lot of people don't understand, when we're talking about get to zero, people who are positive as well, let's get them to undetectable.
Yes.
Which is going to stop that transmission.
Yes.
I think that's the whole point.
That's a U equals U. I was going to wear my T-shirt today,
Right.
but I couldn't.
Yeah, U equals U.
U equals U. So we bring up a valid point, and we hope that getting that message out is going to help us help some of the stigma around HIV.
Right.
So a lot of the stigma is ignorance around how it's transmitted. We have to tell people, no, it's not transmitted by hugging, by kissing, by sharing utensils, by having someone hold your baby. I mean, there's still so much. You would think 30-something years in,
Right.
people would get that. There's still all the stigma around that, but it's transmitted, it's sexual transmission and injection drug use. And it's pretty much serum or blood, vaginal fluid, rectal fluid, seminal
Right.
fluid, breast milk. I mean, it's just, short of that, it's not going to be. And we know that even a pregnant mom, if you give her therapy and get her undetectable, the baby is born without HIV. This
Right.
is in a woman who is living with HIV. And so what you're talking about is this undetectable is equals to untransmittable. That is a huge campaign that we support. Our organization, a lot of countries across the world have signed up to, which means that if somebody is living with HIV, and their virus is undetectable for at least 6 months because they're taking their treatment, they cannot transmit HIV sexually.
Right.
That is a huge message, right? It wasn't something, we kind of said, well, the risk is low. Now we can effectively say, right? So it's called U equals U, undetectable is called transmittable. And we think that by doing that, we'll get more people who are scared about getting tested. Because a lot of people don't get tested because if I'm positive, and that means my life is over. I
Right.
can never have a family, I
Like
can't
a
have
death
sex
sentence.
anymore, I can't do all this stuff.
Yeah.
So if they think about, well, if I get tested and I go on therapy, I can get undetectable and have a normal life expectancy and normal life and sexual and all that stuff, well, maybe I'll get tested. For those people who are worried about, oh my God, this person has HIV, I don't know if I can hug them or kiss them. Well, if you think about in the most intimate, right, sexual intercourse is probably the most intimate thing we do. If they cannot transmit when they're undetectable, they're definitely not going to transmit when they're hugging and kissing you.
Right.
So all of that is going to help with the stigma and get more people empowered. And then
Right.
for people who've been living with HIV, who've been doing their part, taking their meds and undetectable, that's very empowering.
Right.
That's a powerful message. That's enough to then say, some people have been doing this on their own, 15, 20 years, never talked to anybody about it.
Right.
To say, I'm living with HIV, I'm undetectable, have you got tested? Encourage other people to get tested. So that's a very powerful message. And the two tenets of our getting to zero for the state really rest on what you talked about. Getting everybody tested, because if we can get people tested, Then we can put them on prevention, like, something with PrEP to prevent them from acquiring HIV if they're negative. And if they're HIV positive, getting them on treatment to get them undetectable. And we have 7 actually, single tablet regimens where there's 1 pill a day combination agent to get you undetectable. So this is, over the last 20 years, the advances have been pretty impressive.
Yeah.
But we still have pockets of people coming into the hospital, never been tested. I'm on rounds this month, right? This week, I told you I'm on this inpatient. And we still have 30-something, 40-something-year-olds, 20-something-year-olds living in Chicago, born and bred in Chicago, coming into the hospital with a diagnosis related to an infection related to HIV, very advanced HIV, never been tested because they didn't think they were at risk, they didn't think about it, nobody offered them a test. So clearly, we still have a lot of work to be done.
Sure.
And part of our Getting to Zero plan is getting people tested, but also expanding the workforce, right? We have to have more people, and we have to have more young people like you talking about the messaging and figuring out how we can reach, because the younger population is a group that we need to reach.
For sure.
And maybe, people like us and the ones
Definitely.
who should be, we're not doing we have to figure out how to reach people
For sure.
to come in for testing.
And we're talking about these drug regimens
Yes.
that get people to undetectable. Can you explain the difference between PrEP and PEP?
Yes. So, like you said, oh my God, those questions are fierce. Great questions. So, PrEP is pre-exposure prophylaxis, and PEP is post-exposure. So, just like you said, it's exposure prophylaxis pre or post, before or after. So, PEP is really after someone has been exposed, either because of a needle stick. We do PEP a lot, occupational PEP, right, in the hospital where someone's been exposed, or it could be sexual PEP, post, exposure, sex without a condom, with a partner that they don't know, in cases of rape, all other times where just there has been a breach and someone doesn't know the status of the person they're with, then you can actually initiate antiretroviral therapy, the same medicines we treat with right away as soon as possible to reduce the chances of someone becoming HIV infected. So that's a post-exposure, right? The pre-exposure, which is what we're really, really ramping up and doing a lot more of, is to prevent HIV infection. So we have a medication called Truvada. Right now, that's the only medication approved for PrEP.
For sure.
Within the next year, there's going to be something else. And within the next year and a half, there'll probably be other options, including injectables to prevent HIV. But right now, Truvada is a pill that we've used for treatment since 2004. It's been around as part of our treatment combination, not by itself, combined, right, as a regimen, right? And it's part of a lot of our single tablet regimens contain things like that with Truvada or Truvada-like. But now, since 2012, it's been approved for PrEP, where if somebody takes it effectively every single day, the HIV uninfected, so you have to get an HIV test to know that you don't have the right. Get an HIV test, and during that PrEP visit, we do a lot of things. We check for sexually transmitted infections. We check for hepatitis B. So it's a visit that it's actually a good comprehensive visit. And if the HIV test is negative, we put people on PrEP, and it's a pill they take every day that is over 90%. Actually, if taken effective, 99% effective in preventing HIV acquisition. If you don't know, even with with an HIV infected partner or an HIV unknown partner. So that is a big part of getting to zero, both in the state of Illinois, in the HIV elimination plans, is to get more and more people on PrEP, but also as part of a comprehensive panel where we're checking them. And every 3 months, our PrEP prescriptions, we don't just give people a year and say, okay, good, it's part of a counseling, right? So it's a whole sexual health counseling. We test for other STIs. We talk about condom use. We talk about a whole bunch of things and also prescribe PrEP. And then every 3 months, people come in, which do another rapid HIV test. We do, STI screening and things like that, and then monitor the safety while they're on treatment.
Sure. I really hope you guys enjoyed this episode. It was a pleasure. A lot of good information.
Fast, yeah.
It blew by. So please come back next week, every Tuesday at 6:30, and
get tested.
And get tested. All right, have a good
Get
one.
an HIV test.